guys, welcome back. The next topic we're studying is transient ischemic attack and stroke interventions. I'll be here explaining to you regarding when would you do a thrombolysis, what are contraindications for thrombolysis, and even a procedure by the name of mechanical thrombectomy. Now, before we get into the specifics, I want to highlight here regarding this image that I've shown you of Dhirubhai Ambani. Behind him is Bill Clinton and his younger brother Mukesh and Anil Ambani. If you read about Dhirubhai Ambani, the richest man in India, he suffered from stroke. He expired secondary to that. He had his first stroke in 1980s. Luckily, he survived. But in the second one, you will realize that he was having symptoms of transient ischemic attack. But he neglected his symptoms. The richest man could have got any doctor from anywhere in the world. He could have got the best medical health. But since he did not take medical advice, the TIA got converted into stroke. So our objective here would be to see how can we intervene and prevent stroke manifestations in our patient first. And then subsequently, I'll tell you what will be done in case stroke has happened. I also want to highlight here from a non-medical perspective the term FAST. Well, how would you educate ordinary Indian population regarding stroke manifestations would be that if somebody develops a sudden onset, F would stand for face weakness. I know that when I say the word fast, your impression would immediately go for the fast that we talk about with respect to blunt abdominal trauma, where you will be doing ultrasound abdomen to look for the trauma of the important organs. But I am today focusing on aspects related to stroke. You see, if a person is having sudden onset facial weakness and arm weakness, or for that matter of fact, alphabet S would stand for speech deficit developing in a person. He was talking very normally and suddenly the voice just went away. Alphabet T would stand for normally time is equivalent to money, but here I'm saying time is equal to the neurons in the brain. I mean, the earlier you will act, more neurons in the brain you would definitely be able to save. So this is, I would say, a routine information for ordinary population to educate them regarding the danger that is posed by cerebrovascular accident, and this definitely can be intervened in a sense, or it can intervention can be done so that we can prevent the bad prognosis from developing. So let me show this as a representation of any blood vessel in the brain, and my patient was having risk factors like hypertension, cigarette smoking. So there's a thrombus developing at the branching point of the blood vessel, which will cut off the blood supply to the distal areas of the brain. The moment the blood supply to any part of the brain is affected, therefore neurological symptoms can develop, ranging from maybe arm weakness to hemiplegia, or maybe a speech deficit developing in this person. But now the good news is that there is an anti-clotting system in our body as well. The inbuilt anti-clotting system that develops in our body is composed of protein C, protein S, and antithrombin 3, and they will immediately get into action that there is a clot and it has to be disintegrated. Therefore, I will now modulate my diagram once again. This is the same blood vessel that I had shown had undergone a complete occlusion few minutes earlier. Now the thrombus has been disintegrated. You can see that the thrombus is very much there, but there is still some luminal flow that has been re-established. I agree that some of the fragments of the clot will be distributed to the distal circulation, but at least thankfully some blood supply is present to distant tissues. Therefore, the neurological symptoms of this person will begin to regress and then subsequently might disappear also. I want you to remember that in transient ischemic attack, the improvement usually begins as early as 1 hour, but if they ask you what is the cutoff or what is the upper limit of improvement, it would be 24 hours. I repeat that fact once again. You see improvement in transient ischemic attack. Like for example, this 70-year-old guy is a cigarette smoker, hypertension patient with traditional risk factors for atherosclerosis, is having an arm weakness. If TIA is getting converted into stroke, then improvement will never occur. The weakness will progress and even other parts of the body will get involved. But if it is a transient ischemic attack, in most of the cases, because we are calling it transient, that is why I'm saying, because the thrombus was disintegrated, so the resolution usually occurs by first hour only. Obviously, the upper limit is 24 hours, but please remember, if resolution has not occurred by 1 hour, then it will mostly progress into stroke, and that means that if it is ischemic stroke, you will have to do thrombolysis. You see, the window period for acute ischemic stroke within which you need to do thrombolysis from the onset of symptoms is 4.5 hours. So it is important for you to understand that whether it is a case of TIA, whether it is a case of stroke, the message is loud and clear. If a person has a neurological deficit of sudden onset, fast is what I said, then if the symptoms are to improve, they will start improving by usually 1 hour and will completely disappear by maximum of 24 hours. But if they keep on progressively increasing, even if in a stuttering fashion, it would be a development of an evolving stroke in a patient. There have been MCQs in the exam regarding the cutoff for transient ischemic attack. The upper limit of improvement is usually within 24 hours. If symptoms persist beyond that, it's obviously a full-blown stroke, and the person is even beyond the window period now, so you need to make a quick diagnosis. Imaging will be normal in patients of transient ischemic attack. I want to highlight the fact that when it comes to imaging in an acute ischemic stroke, again in the early phase of ischemic stroke, imaging can be normal. So how will I make a diagnosis? Clinical grounds, like if the neurological deficit is persisting after 1 hour. Even if the CT scan is normal, I will still be doing thrombolysis in the patient, guys. Why? Because you see, the reason why you do a non-contrast CT scan is not to identify a ischemic stroke. Radiological finding of ischemic stroke might take 6 hours to appear. You're not going to wait for 6 hours and then say, okay, it is ischemic stroke. Because the cutoff period is 4.5 hours. Please remember, CT scan is done in a case of stroke primarily to rule out hemorrhagic stroke, which is a contraindication for thrombolysis. If neurological deficit is persistent for a duration more than 1 hour, even if the CT scan is normal, you have to do thrombolysis in the patient. The learning at this point of time is TIA is a precursor for stroke. It can definitely be taken care of. So let us now look at how my patient will present. So I'm just giving you a scenario of a 60, 70-year-old guy. Traditional risk factors for atherosclerosis are present in the body of this guy. Like he's a known case of hypertension, non-compliant, and smokes on 1 packet of cigarette every day. He was maybe watching television news. He was watching the coverage with respect to COVID-19, like now the vaccines have been introduced for COVID-19. So he was discussing with his son or grandson about how effective these vaccines will be, and will he be, because he's a senior citizen, will he be the first one to get these vaccines? While he's discussing this with his son and maybe he's watching television simultaneously, this old man will tell you that suddenly I felt as if there's a curtain falling in front of my eye. I just lost vision in either my one eye or both eyes. You see, most of these patients will be becoming totally blind. The unfortunate news is that there is a thrombus which has occluded the ophthalmic artery of this person, because of which he will become blind. Over the course of next few minutes, protein C proteinase antithrombin 3 will now get into action, and there's a possibility that the vision in one eye or both eyes of this person will come back. I basically wanted to highlight that this person went blind for maybe few seconds to few minutes. There is a transient onset blindness which is developing in this gentleman over a matter of, let me say, few minutes. The technical term for this is called as hemiurosis fugax, and this is possibly one of the symptoms that can develop in these patients, secondary to the fact that one of the branches of the internal carotid artery, the ophthalmic artery, got involved. Now, it is not a hard and a fast rule that only ophthalmic artery will be blocked. Sometimes there could be a thrombus in the middle cerebral artery, but thankfully protein C proteinase were again coming to the rescue. What is going to be the symptom? This guy was maybe standing in front of the wash basin and he was shaving. So he says that suddenly the shaving razor fell from my hand. He thought it is accidentally falling from the hand, but then he soon realized that he was not able to retrieve the shaving razor which had fallen in the wash basin with his, let me say, the left or the right hand, whichever side the weakness is coming. He will be able to use the contralateral hand. Like suppose weakness is in the right, he can definitely use the left hand, but he will not be able to retrieve with that particular hand. So he thought that, okay, something went wrong with my nerves in my arm from a non-medical perspective. So he tried to call out to his son or daughter or grandson, whosoever is in the house. But then he realized that he's not being able to speak. This guy says, doctor, I got the shock of my life. I thought, what's going to happen to me? My arm went numb. I could not move it. I could not even speak. And then when I looked at myself in the shaving mirror, because there would be a mirror in front of the wash basin, he says one of the side of my face was sagging. There was even a face weakness developing in this guy, and this persisted for a few minutes to maybe 20-25 minutes, maybe 1 hour, and then gradually disappeared. So he says, sir, I don't want this to happen to me again. In transient ischemic attack, neurological symptoms will come and disappear, and as I explained to you, the resolution, if it has to occur, will occur usually by the first hour, and the upper limit of resolution is 24 hours. Another patient is telling me that, sir, I was sitting on the chair watching television and listening to COVID-19 coverage on the television. When I felt as if I have become wheelchair bound, I could not move my legs. He says upper part of my body was fine, but I could not move my legs. There was either a paraparesis or a paraplegia. And he says for the first few minutes, I thought I will be wheelchair bound for whole of my life, but gradually the power in my legs came back. There's another patient who tells me that, sir, while I was drinking water, The water started coming out of my nose. You see, this guy started developing a ninth nerve palsy. There's gonna be a nasal regurgitation of fluids developing in this guy, thanks to the cranial palsy that is secondary to vertebral artery involvement, because vertebral artery, as I explained to you in the previous lecture, would be supplying the brainstem. Even the voice of this patient will look very peculiar. His daughter or granddaughter is thinking that grandfather is sounding so funny. Nasal twang to the voice will again come because of glossopharyngeal nerve palsy. Not all patients will be having only motor manifestations. Some might be having even sensory manifestations in the form of pins and needles. Please appreciate the fact that I do not need to have all the manifestations described here to call it a transient ischemic attack. If even any one of the symptom or symptoms that I've described before you is present and then is resolving by itself. The message is, if any one of these symptom or symptoms is developing, the neurological symptoms is developing in a patient, and there is going to be a spontaneous improvement. The person himself has to say, yes, I feel better, because the speech would come back. So there would be a spontaneous resolution that is occurring in the patient. As I've told you, if resolution has to occur, it usually begins by the first hour and usually clears up by a total of 24 hours. And simultaneously, when I did a imaging in the patient, the imaging was perfectly normal. So now, because there is no deficit, no need for thrombolysis in this guy. I basically wanted to explain to you how transient ischemic attack will occur in a patient. The learning for us is that transient ischemic attack is a warning symptom for development of stroke. Now, can you as a doctor predict whether somebody will develop stroke or not? We as doctors have been working on this for a very long time. So I will now teach you a scoring pattern which is very frequently asked in the exam that can actually help you predict what is the percentage chances that somebody will or will not develop stroke. And now I want to tell you that the highest chances of development of stroke are seen in the next 48 hours. Next 48 hours are important for this. Please do not mess up between the time frames. I said improvement usually will start by the first hour. Upper limit of improvement for TIA is 24 hours. But look at what I said now. The 48 hours cutoff that I've said is not for chances of development of stroke. The 48-hour cutoff is, I'm saying, the highest incidence of stroke development occurs within the first 48 hours. So had Dhirubhai Ambani sought medical advice in that 48-hour window period, there's a distinct possibility that he may not have expired. Though I'm speculating that, but the point is, if we educate people about fast, the moment they develop TIA, if they come to us, we can prevent the development of stroke. How? We can start them on dual antiplatelet therapy. By dual antiplatelet therapy, I mean combination of aspirin and clopidogrel. Dual antiplatelet therapy was told to you earlier for management of ST elevation MI, but now is being taught even in management of transient ischemic attack to prevent the development of stroke. Now, before I start talking about what other drugs would be recommended, let us just talk about that scoring pattern available, which is called as ABCD2 score. And nowadays, there are so many apps available which doctors who are practicing can actually download, and you just need to feed the data. And therefore, when you press on the submit button, the app will tell you what is the percentage chances of development of stroke. Let's practice this. Alphabet A would stand for age of the patient. If it is more than 60 years, you will give 1 point for it. You don't need to remember the point system. Just remember the full form. B would stand for blood pressure. Obviously, if the cutoff for hypertension, that is 140/90 or more, is there, you will again give 1 point to the patient. Then comes C, clinical features. In clinical features, there are two of them. One which is very characteristic and a person can appreciate is weakness in the arm of sudden onset, which is given 2 points. Whereas when it comes to aphasia, this would basically imply that the dominant parietal lobe blood supply is gone in the person. The superior division of the middle cerebral artery, the left middle cerebral artery is gone. So we will give 1 point. Similarly, alphabet D would stand for duration. Now, there's a possibility that the manifestations disappeared within 10 minutes itself. So we will give 0 points for this. If the manifestations are between 10 to 59 minutes, we will give 1 point for it. Again, I'm highlighting you don't need to cram the points. I'm just trying to sensitize you to the fact that longer is the duration of manifestations, more are the chances of development of a stroke. Then in the app, it will ask you, is this person a diabetic? You will have to select between yes or no. Obviously, no will be having a 0 mark and yes will be having a 1 mark. So I am creating a worst case scenario for you. The worst case scenario of mine is if age blood pressure, arm weakness is there, symptoms are persisting for more than 60 minutes, diabetes mellitus is yes. If I add up all the manifestations, the score is turning out to be, let me say, 7. I mean, the max score possible with respect to ABCD score is 7. If there is a rating of 7 coming up on the total score, then there is 22% chances that this person will develop stroke in the next 48 hours. If I just extrapolate 22 to 25, out of every 4 TIA patients that come to your OPD, one person can develop stroke. What variety of stroke will it be? Ischemic versus hemorrhagic? You can't predict, right? That is made on basis of CT scan. Lots of guys send me messages saying, sir, can you differentiate clinically between a ischemic versus a hemorrhagic stroke? No, there are some subtle hints, but otherwise you just can't, by looking at the person, say, okay, this is ischemic stroke patient, this is hemorrhagic stroke patient. Imaging is of paramount importance. Here we are not trying to get into what kind of stroke is present. First point is easy having our chances of development of stroke or not, because I obviously need to use drugs to prevent that from happening. There is approximately 22% by the textbook. I'm extrapolating it to 25%. So for every 4 patients of TIA, 1 patient can definitely go into stroke. So this is a warning symptom for educating ordinary population. I mentioned about fast, and if you just get ABCD score, ABCD2 score right, I'm very sure that you would be ready with the initial questions that come on the topic. The second important point that I want to highlight once again is, if it gives you a question in which neurological symptoms have begun to improve, then it is a TIA. If they are not improving, it is acute ischemic stroke, guys. Radiological finding of AIS will take some time to develop. Ideal way to image acute ischemic stroke is diffusion weighted MRI, but in government hospitals, most of the time we don't have a DW MRI, so we will have to base on practical situation that there's a non-CT scan, non-contrast CT scan only available. If neurological symptoms are not improving, even if CT is normal, I will give thrombolysis to the patient with retaplase in the first 4.5 hours. That is the cutoff, that is the window period, and the window period is calculated from the symptom onset. Let us now look at the investigations that we will do in this diagnosed case of TIA on the basis of ABCD2 score, and then decide the treatment of this patient. In the workup of this patient, the first test that I will get done will be a ECG. Why? Because I want to rule out the possibility of atrial fibrillation. You see, there's a possibility that this guy is a alcoholic patient on a long-term basis. He has developed chronic alcoholism and then a alcoholic dilated cardiomyopathy, which is a trigger for atrial fibrillation. The atrial fibrillation will contribute to formation of clots in the left atrial appendage, and then any one of these clots can actually go into the brain and can contribute to manifestations of cardioembolism in this guy. In fact, this is one of the leading causes of embolic stroke, that is non-rheumatic atrial fibrillation. Towards the end of this lecture, I will enumerate the causes. On one of the important ones that I've highlighted, and I'll speak once again, is non-rheumatic atrial fibrillation. Now, suppose if ECG turns out to be normal, I can still do a echocardiography. I will be comfortable doing both transesophageal as well as transthoracic echocardiography, because you are very well aware that atria are posteriorly situated. So transthoracic is more suitable for the ventricle evaluation, whereas for atria per se or atrial appendage, it is a transesophageal echocardiography, relatively more suitable. The objective of echocardiography is to identify a clot developing in any of the chambers of the heart. That's mainly related to the left side, and mural thrombus is the one that I'm looking for. But suppose ECG and echo both are normal, and the relatives of the patient are asking you, sir, you scared us, you told us there is some clot coming from the heart. From where is it? I'll tell, there is a distinct possibility that the clot could be originating not from the heart, but from the carotid artery. This guy could be having atherosclerosis of the carotid artery. How would I pick up the atherosclerotic narrowing of the carotid artery? Because you see, atherosclerotic plaque, if shears, if there's a tear in the atherosclerotic plaque, platelets will come and jump over it. There would be a thrombus formation, and this thrombus can then disintegrate, and the fragments are going into the brain circulation, which are causing TIA symptoms. The test that I can do for evaluating the carotid artery of this patient is a carotid artery Doppler. The objective is to identify the atherosclerotic narrowing of the carotid artery of the patient. Now the problem is, lots of time the atherosclerotic narrowing may not be picked up. Why not picked up? Because if it is only 20-30% narrowing, the Doppler technique may not, because it's user dependent, may not be able to pick up the narrowing. In those circumstances, lipid profile will definitely come to rescue, because if somebody is going to be having an atherosclerotic narrowing of any blood vessel in the body, lipid profile will definitely coming or will turn out to be deranged, and that's very common in Indian population. I will be able to demonstrate hypercholesterolemia or elevated triglycerides as well. The LDL values will be very high, HDL values will be reduced, and lots of time in Indian population there could be another, I would say, silent marker that has to be picked up: elevated homocysteine levels, because homocysteine can also contribute to both coronary and cerebral thrombosis, and therefore the bad news is the person will end up with clot formation. Now, once you know that these are the baseline minimum investigations to be done, let us now summarize regarding the treatment which will be done in this patient. And lots of time in India, because let me say if it's a weekend, it's a Saturday or a Sunday, investigations may not be possible. Don't wait for investigations to be done. Start at least the patient on DAPT, that is dual antiplatelet therapy. In dual antiplatelet therapy, the first thing that you will start the patient on will be aspirin, that would be 300 milligram. This is the loading dose that you need to give, along with clopidogrel, another 300 milligram. Please remember the fact that from tomorrow, you will instruct your nurse to shift this person onto the baby tablet of aspirin and the baby tablet of clopidogrel, and therefore we will be able to reduce the thrombogenic potential in this person. On this, the query of lot of doctors is that what is the need for dual antiplatelet therapy? Why can't you give only clopidogrel? Why so? Well, from Indian population perspective, guys, you see most of the Asian population, especially Indian population, there might even be resistance to clopidogrel, or clopidogrel may not be effective. You see, lots of time you will read about cytochrome P450 system in the liver. There is a data that's given in the textbook with respect to especially Asian population or Indian population having this polymorphism called as CYP2C19. Well, the problem with these people with this polymorphism is that clopidogrel will be neutralized by the liver. There will be relatively a poor response. I mean, clopidogrel will not be able to exert the exact effect that it actually should in a Western patient versus an Indian patient. So, on account of poor response to clopidogrel, especially in Asian population, he says, why to take a chance? Give a combination. Anyway, the efficacy has been found to be superior. You see, I'm telling you two aspects. I'm saying why DAPT. One is the efficacy part is relatively better, and second is the fact that clopidogrel might be actually not working very well in Indian population. Now, because of lipid profile defects being so common in our country, I definitely have to start my patient on high intensity statins. That would be like a 40 or 80 milligram atorvastatin to be given regularly. Yeah, I agree. Subsequently, muscle pains might occur. So you can monitor the patient with CPK-MM, because a statin induced myopathy can be a side effect. You will also give to the patient vitamin B6, B9, B12. Why these? Because vitamin B6, B9 and B12 are useful for treatment of homocysteinemia. And the next point is to be listened with lot of care, because this is going to be used only if I demonstrate the presence of clots. If I demonstrate a mural thrombus, if I demonstrate clots in the left atrial appendage of the patient, then I will definitely have to use NOAC, that is novel oral anticoagulants, and the two that you have been taught are one by the name of rivaroxaban. In fact, novel oral anticoagulants are the hot favorite of our examiners nowadays. So I would definitely like you to read up the pharmacology domain behind it. And if I start my patient on NOAC, then I can definitely reduce the incidence of cardioembolism. I mean, whatever had happened, but at least I'm going to neutralize the impact of these clots in future. And I can also use this opportunity to mention regarding the mechanism of action of the drugs. How does rivaroxaban act? How does dabigatran act? So the mechanism of action is hidden in the alphabets itself. In rivaroxaban, alphabet X is coming, so this would be a factor 10 inhibitor. And when you talk about dabigatran, alphabet T is coming up, so this would be a direct thrombin inhibitor. You anywhere familiar about this from pharmacology? It is just that I decided to brush up a bit for you. And on the basis of this approach, that is DAPT, NOAC, statins, and vitamin B complex and B6, B9, B12 specifically, I will be able to reduce this chances of development of stroke. Obviously, we cannot exterminate the chances of stroke. It might still occur. You would have seen patients who are on these medications still end up with development of stroke. So there's always a limit to which medical science can control the progression. But first thing is identification of the disease. identify how bad it is. First is identification, TIA. Second is how bad the TIA episode is. I mean, what are the chances of development of stroke? And the duration will be an important criteria there. Neurological manifestations will be important criteria there. And assuming the fact that if a person has not reached the hospital, then the chances of stroke development are substantially high. So now I'm going to create a worst case scenario for you. What I mean by worst case scenario is that this particular gentleman, he actually developed stroke right early in the morning. So let's have a look at how the manifestations have occurred. I will just deteriorate the previous patient once again. This 60-year-old man, the only good habit that he has is that he goes for a morning walk, and there are other people of the same age in the same society in the same tower, so they just chat around, walk around, and then he comes back and takes a bath subsequently. So this is his daily routine. He gets up at 6, goes for a morning walk after having a cup of tea or coffee in his house. Today morning also he got up, his wife made him a cup of tea or coffee, and at 6:30 a.m. when his wife came out to the kitchen, she found him that he is still sitting on the sofa. His sports shoes are very much there. He's wearing the sports shoes, but she just casually asked him, did you not go out for your morning walk today? I mean, normally you do. And she found that her husband was struggling to speak. This lady initially was taken aback. I mean, she was wondering what's going on. His lips, he's trying to as a produce voice, but the voice is not coming out. So this particular person at 6:30 a.m. has been noted by his wife to be having inability to speak. So she thought that maybe some medical problem. She thought, I'll call up the doctor. So she told him, don't worry, you'll be fine. And she handed him over a glass of water. Like, say, anybody sick in India, the first thing a wife or a husband would be, or I mean, family member would be doing is giving a glass of water to the person and say, okay, we'll call up the doctor, don't worry. So when his wife handed him over a glass of water, she found that he was struggling to raise his right arm. He could use his left arm, but right arm power was not there. He was maybe trying to support and maybe point that I'm not able to use this particular arm. One particular arm was fine. So there are two features that has developed in this guy. One is a right arm weakness, and second is that he's not being able to speak, which definitely will send the alarm bells ringing in mind of everybody. Let me say the call came to the hospital. Ambulance has also reached the residence of this guy, and by 7:30 a.m. this particular individual is in my hospital with the following symptoms, and I have noticed that the symptoms are still persisting. When I'm physically examining this guy, I have noticed and asked his wife to compare. She says, sir, the symptoms that came at 6:30 are very much there. They have not reduced at all. When I did physical examination, I did notice a Babinski sign coming up, because once the brain is damaged, there's a possibility that corticospinal pathway irritation will contribute to Babinski signs. So extensor plantars may be elicited. In the MCQ, he might write the word Babinski sign, extensor plantars, long tract signs, or Chaddock sign, Gordon sign, all the terms that I've used earlier. I mean, any of the surrogate terms of corticospinal involvement can definitely be given. When I did a fundus examination of this guy, it was normal. Now here I want to tell you that just because fundus is normal, that does not mean that you have ruled out hemorrhagic stroke. In fact, hypertension patients, the impression of a lot of doctors is that hypertension patient hai, to hypertension patient will always develop hemorrhagic stroke. That is not the case. A lot of hypertension patients might be developing ischemic stroke. Guys, 85% presentation is of ischemic stroke. So when you are examining this guy, don't be under a bias that hypertension likha hai. If hypertension word is given, that means he is talking about hemorrhagic stroke only. When I did examination motor of the person, I noticed that the right arm of this person, the power was only 1/5. He was hardly able to move the right arm of his, both at the shoulder joint and the arm at the elbow joint. The power was very minimal. Since I'm noticing a focal neurological deficit, I have ordered a CT scan. I have explained to you, and I'm highlighting this fact that door to CT scan time should be approximately 20 minutes. So if he arrived in my hospital at 7:30 a.m. in the morning, by 7:50, a non-contrast CT scan has been ordered for this guy. The door to CT scan time in a suspected case of stroke should be approximately 20 minutes, and CT scan interpretation is approximately 45 minutes, and that is what I have been able to do successfully in this case till now. So far so good, guys. The basic point is, in any suspected case of stroke, you must be having a guideline, and I reiterate this guideline. Door to, you can just see the timelines, 20 minutes, 7:30 to 7:50, that's what I've highlighted, and then 45 minutes here. So door to CT scan time and door to CT scan interpretation time both should be known to you. I repeat the fact, door to CT scan time 20 minutes, door to CT scan interpretation time is 45 minutes. And now based on the CT scan report, I'll decide treatment for this guy. I want to once again reiterate, guys, please remember, in this guy in whom the symptoms are persisting, if it is ischemic stroke and is presented within 1 hour, CT will be normal. Most of the time CT findings in ischemic stroke might take 6 hours to appear. I'm not gonna wait for 6 hours for findings to appear and then start treatment. Even if the CT is normal, I will still thrombolize this patient. Now, assuming the fact that the NCCT head report of this person has come, there can be two possibilities. Either it's gonna be hypodensity. I'll just zoom it in. You can notice a very clear-cut hypodensity currently on the slide, which is suggestive of acute ischemic stroke, though this finding might take 6 hours to develop. I'm not going to wait for 6 hours though to start thrombolysis. The window period for starting thrombolysis is 4.5 hours. So even if the CT scan is normal, I would still decide to do thrombolysis in AIS. In contrast, when you look at the contralateral image that I'm going to now bring into focus, it's very easy to identify the extravasation of blood in the brain parenchyma. It is an intraparenchymal hemorrhage. So since it is showing a hyperdensity, the diagnosis of the patient will be kept as hemorrhagic stroke, and my objective would be to then control whatever bleed that is occurring by controlling the blood pressure of the patient and lowering the raise ICP. In contrast, when it comes to the left-hand side of this discussion, you will notice a hyperdensity that I'm zooming in right now. So query from a lot of doctors is that, sir, you said hyperdensity for brain hemorrhage, then how come hyperdensity is present even in a ischemic stroke? Well, the logic is, guys, when the clot will develop in the lumen of the middle cerebral artery, like what is shown here is called as dense MCA sign, or sometimes written as hyperdense MCA sign. The concept is when the thrombus is in the stage of formation, it will initially look relatively hyperdense to you. This is an initial finding in a case of acute ischemic stroke, and then in the same patient, after a few hours, you will notice a deterioration and there will be a hypodensity developing subsequently. The learning is that if I have to answer AIS, acute ischemic stroke in a patient, the CT scan can initially be normal. Then there can be this radiological finding that I just explained, dense MCA sign, and last possibility is after a few hours it will evolve into a hypodensity, but we are not going to wait for the hypodensity to become full blown and subsequently you would manage the patient. Now, what are the steps in management? They're again important. Don't straight away start with thrombolysis. Like if I look at a broad perspective, it could be AIS, it could be hemorrhagic stroke. So the initial steps that would be taken would be of airway, breathing and circulation. So I want you to understand the fact that don't straight away start with thrombolysis in AIS. First is basic steps of airway, breathing, circulation. Then you also need to monitor the sugar values. You see, if sugar is more, even then it will cause problem because it will increase the swelling in the brain. And anyway, sugar lesser will starve the neurons. They anyway have to fight, the damage present. So I want them to be having good supply of sugar. So if the blood sugar is turning out to be less than 60 or more than 200 milligram percent, both circumstances can be detrimental. If there's a hypoglycemia documented, you can definitely supply 10% dextrose. If it is going to be elevated, even insulin drip would be given. Now, assuming that you have taken care of the baseline problems in the patient, then the main treatment for the left hand side is a retaplase, provided the patient comes on time. Lots of time in India, patients might come very late. Like somebody went to sleep at 10 p.m. in the night and he woke up with features of stroke. Then what will be the timing of onset? Then the timing of onset will be taken from the time he went to bed. Like let me say he went to bed at 10 p.m. in the night, woke up at 8 a.m. next morning with symptoms of stroke. So what is the timing of onset of stroke? 10 p.m. last night. So already the window period is crossed. So in that case, you are not going to do thrombolysis. Lots of time in India, you will have this history present that my dad was okay before he went to bed. He developed stroke in his sleep. So we can't predict at what time did he develop stroke in his sleep. We will take it from the timing of the time, or rather the time that he lied on his bed, or the family members realize that okay, he's sleeping. From that time we'll take the onset of development of stroke. The learning for us is retaplase should be given within 4.5 hours of symptom onset. If somebody woke up with features of stroke, then we are not going to give retaplase to the person. The dose of retaplase is usually 90 milligram. I'll talk about the dose also subsequently. But let us now see what are we going to do for those patients, especially those who come late. Like suppose a person reached to you at 5 hours or 6 hours after onset of stroke. In those circumstances, you see the family was bringing this patient, but then there was a protest by the farmers on the highway. So the ambulance got delayed. Now his son is asking you, sir, we are late by only half an hour. No, like suppose they came at 5 hour period. They say, sir, you are displayed in a hospital that you do treatment of AIS within 4.5 hours. We late by half an hour. So what? So I will say, no, now he's not a candidate. We will rather be doing a procedure that is called as mechanical thrombectomy. Well, obviously that will require a lot of facilities, but this is the protocol that I want you to remember. In mechanical thrombectomy, we are gonna physically grab the clot and come out. In fact, you all would have read about this brand name Mercy. Mercy is actually a brand name for mechanical thrombectomy. Let me just give you the full form of it so that you will feel more comfortable. In fact, lots of times this would be displayed in the hospital waiting area also, that Mercy procedure charges are this much. So Mercy basically stands for mechanical, E would stand for embolus retraction in cerebral ischemia. You can very well understand if there's going to be embolus, cardioembolic happens to be the leading cause of stroke from atrial fibrillation. So mechanical embolus retraction in cerebral ischemia is the brand name that I want you to remember, and both of them basically mean the same. I want to highlight this and put it on record. Patient went to sleep. In fact, I'm writing it for your convenience. Patient went to sleep at, let me say, 10 p.m. in the night. This is a retired person, so usually sleeps, around about this time. Unlike us, we are night crawlers, most of us doctors. He awoke with stroke symptoms at 8 p.m. in the morning. In those circumstances, we are not going to do thrombolysis because the onset of stroke in this case is going to be taken as 10 p.m. He has presented to us very, very late. This is just a general scenario that I'm telling you, that you're not supposed to do thrombolysis. Another issue or a message that I get from lots of my students is that are we supposed to give aspirin to a person of ischemic stroke? You see, you are obviously not going to give aspirin to a person of hemorrhagic stroke because he's having a bleeding. Aspirin will worsen the bleeding. But would you give aspirin in a case of ischemic stroke? Then the answer is yes. You see, you need to give aspirin after 48 hours of completion of thrombolysis. If you have done thrombolysis in a patient in the first 48 hours, do not give aspirin, obviously because of the risk of bleed. But after 48 hours, you will give aspirin. Why? To prevent the redevelopment of stroke in a patient. I highlight the fact once again. Why do you give aspirin after thrombolysis? Not immediately. Well, it will increase the bleeding chances. Why do you give it after 48 hours? Is to prevent a second episode of stroke developing in this person. I want to highlight the fact that straight away when you get a question, don't comment on whatever type of stroke is present. Clinically, we cannot differentiate between what is the type of stroke that is present. But yeah, some clinical pointers will always be there. Like if he begins by a patient who's having a hypertensive crisis, and he says that the deficit of this person is increasing gradually. Like when he came, he was having paralysis in only one arm, but now, let me say, even the trunk has got involved, and earlier he was able to speak, now he's not able to speak. So if you are getting a scenario of these two facts, it is suggestive. I'm not saying it is guarantee, it is suggestive. And along with that, there will be decrease in the level of consciousness also, because raise ICP is the main problem in a person of hemorrhagic stroke. As the clot will expand, it will contribute to pressure on the ventricular system, causing obstructive hydrocephalus. So what am I going to do in this case will be slightly different. Obviously, thrombolysis is going to be contraindicated in this case. So I will first be trying to lower the pressure in the brain using osmotherapy. Well, can you use mannitol in a person of brain hemorrhage? Yes, you can use mannitol because now the bleed has stopped due to tamponade effect. If it's an active bleed, we do not give mannitol, but now the bleed has already stopped. So we definitely now need to lower the pressure in the brain using osmotherapy. Another approach is perform a ventriculostomy in the patient, that is discussed in the topic of raise ICP that I have taken separately. And in some cases, in fact, in spite of ventriculostomy, the pressure is not controlled. You might have to go in for a decompressive hemicranectomy. Similarly, the very high blood pressure of this patient has to be regulated using nicardipine because he is giving you a scenario of hypertensive crisis. Instead of nicardipine, we can use labetalol, we can use esmolol. I mean, avoid answering sodium nitroprusside per se. Why? Because sodium nitroprusside causes a sudden fall in blood pressure. If you fall the BP suddenly, then you will use the brain perfusion, and therefore the brain infarction component will come up. You see, I have taught you a formula. Cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. If you will lose the mean arterial pressure, then the cerebral perfusion pressure will also reduce. So one hand there was problem due to increased BP. Now when you suddenly fall dead, there will be brain infarction, and that can actually deteriorate the patient as well. The minimum learning from this slide is 4.5 hours is the window period for management of stroke. This 4.5 hours is taken from where? It is not taken from entry into the hospital. It is taken from the symptom onset. 4.5 to 6 hours, it is going to be a mechanical thrombectomy that might be done in a patient. In the older edition of Harrison, in after mechanical thrombectomy, another approach was also mentioned, that was intra-arterial retaplase. For intra-arterial retaplase, I will just say that this is like playing with fire, because when you will give intra-arterial retaplase, you are giving the thrombolytic drug directly in the blood vessel that is blocked. God forbid, if this causes the biggest side effect, bleeding, you will convert the ischemic stroke into hemorrhagic stroke. Now imagine yourself telling family member that your father is having one particular X variety of stroke. They don't understand ischemic versus hemorrhagic. They just understand our father has had a variety of stroke. You are telling them the side effect is that I can convert this stroke into a different variety of stroke, which might be even much more severe than the previous one. His son will fold his hands and say, sir, I don't want this treatment. So intra-arterial retaplase obviously has a disadvantage of causing a life-threatening bleed as well. So this is something which I said is something like playing with fire. In fact, the more appropriate approach would be go bang in the blood vessel, do angiography, go in the blood vessel, retract the clot in one pace, and the procedure of Mercy I have described even in the animation section of the app as well. So let us just summarize what are the indications for thrombolysis that you are familiar with. From the cardiology section, I have taught you that thrombolysis is always done in a case of ST elevation MI, provided PCI facility is not available, and the window period would be approximately 12 hours. Today I have taught you for acute ischemic stroke, and when you scroll down in the respiratory section, you will again see me talking about thrombolysis in a case of massive pulmonary embolism. In contrast, what are the times you will study thrombolysis is contraindicated? We do not do thrombolysis in non-ST elevation myocardial infarction. Reason is given in the cardiology section. We do not do thrombolysis in hemorrhagic stroke, obviously, because that will worsen the chances of, or whatever bleed is present will definitely increase. We do not do thrombolysis in pulmonary embolism. The logic behind this is given in the respiratory section. We do not do thrombolysis if the systolic blood pressure is dramatically elevated with systolic more than 185, diastolic more than 110 millimeters of mercury in spite of medication. You see, I have already given, let me say, nicardipine to the patient. I have already used labetalol, but the blood pressure is not coming down. My primary objective is first lower the BP lower than this. Why? Because if you give a thrombolytic drug with this high a BP, the bleed is going to be torrential. So I don't want to take a chance. If a person is having bleeding diathesis, bleeding tendency, then again, first correct the bleeding diathesis, then do thrombolysis in a patient. Other contraindications are relatively easy to pick up, so I usually don't find people making a mistake in the subsequent ones. Like if a person had a recent head injury, or there is a documented intracranial hemorrhage in a patient, maybe 1 week back, 2 weeks back, we will not do thrombolysis. If a patient has got any major surgical procedure done in the previous 2 weeks, you see, when whatever I'm writing at the lower part of the discussion, it is still easily understandable, because suppose a person had a very severe torrential GI bleed, like he had a peptic ulcer disease and that bled in the previous 3 weeks, I'll be a little wary. If a person had recent myocardial infarction and was thrombolized, the word is recent MI, or if it's going to be a recent MI in the previous 6 weeks, because he has already been subjected to thrombolysis. So the inferior data is still easily relatable, but the superior ones are, I would rate them as important ones from this particular slide. So please make a list of this, maybe on a stick-on pad, and try to keep it with you so that you can remember the information. For STEMI, I would like to highlight that the window period is taken to be 12 hours from symptom onset. In AIS, it is 4.5 hours from symptom onset. Both the informations provided to you are not from the time of entry into the hospital. In cardiology, I've taught you door to needle time, door to balloon time. Those are separate issues for percutaneous coronary intervention and starting a thrombolysis. You can refer to the cardiology section for that. But please do not mess up the onset, right? Onset here is from symptoms and not from entry into the hospital. And I usually find a lot of guys making these kind of silly mistakes, so definitely have to be taken into consideration. And if you're getting a hang of this particular slide that I've highlighted, I mean the interventions which are to be done, you would definitely be able to solve the questions. And the most important point that I've highlighted time and again is progressive neurological symptoms persisting for more than 1 hour. Even if the CT scan is normal, it is acute ischemic stroke. Start treating the patient. Would you give aspirin in AIS? Yes. When would you give it? After 48 hours. I will now be explaining to you regarding the etiology for development of stroke. So we will have a look at why. And I'll first talk about 15% of the cases which are going to be hemorrhagic stroke. The initial causes are going to be straightforward, and especially the last one that I highlight is important from the exam perspective. Well, the standard ones can be hypertensive crisis, then can be trauma, then can be vitamin K antagonists. He can write VKA, or he can just specify the word warfarin toxicity. From pharmacology, you are familiar with the fact that for treatment of warfarin toxicity, our first answer will be a ready-made source of clotting factors, that is prothrombin complex concentrate, to be given to the patient. If prothrombin complex concentrate is not in the options, then we shall be giving FFP, that is fresh frozen plasma, to the patient. But first answer is PCC. We are nowadays extensively using novel oral anticoagulants also in various situations, so they can also be a chance of dabigatran toxicity. Though they teach you in pharmacology that the chances of bleeding with especially dabigatran will be very limited or will be relatively lesser, but yes, if it will occur, we have to be ready. So we do have a monoclonal antibody that we will be using for management of this condition, and it can help you tide over the crisis. The name would be idarucizumab. Well, the names have to be remembered, PCC and idarucizumab. The next cause is, which is the most important one on this particular slide. So I'm describing a very old man. He's about 80 years of age, and his complaints are that he has pain in his knees due to osteoarthritis of his knees. He was coming to me regularly to the OPD for a checkup. I had suggested him to go for a total knee replacement surgery, but unfortunately he did not listen to me for this knee replacement surgery, and today he has had a brain hemorrhage. His son is asking me, not in a blaming fashion, but he's saying, sir, my father was having good health. I mean, why his son is saying good health? Because he says, my father was not a diabetic, not a hypertensive. He did have problem with his knees. He was coming to you for follow-up. But why did today my dad have a brain hemorrhage? And that too, so bad that he woke up with stroke manifestations. And by the time we took him to the doctor, the intracranial pressure increased so dramatically that he had a posturing and he expired. I will explain to his son that in old age, the brain blood vessels can become fragile, and the condition responsible for this is called as cerebral amyloid angiopathy. Why it is important from the exam perspective is because this is a manifestation developing in a non-diabetic, non-hypertensive patient. So whenever you read this scenario that I have written for extremely old age person, CAA should definitely be considered. And that highlights, I mean, I agree hypertension is the commonest one, but then non-hypertensive patients can also die because of chances of development of stroke. Now let's focus on the remaining 85% of cases. So lots of data coming up here. Why would a person be having a development of acute ischemic stroke is the objective. Lots of time in the textbook, the first cause will be given as unknown, but obviously we are not worried about the unknown component. We are going to be worried about what we actually know and can definitely intervene and control also. So one of the important reasons for embolic stroke can be clots coming from the heart. This patient is having non-rheumatic atrial fibrillation. Well, the story is that he was an alcoholic, let me say, and he developed dilated cardiomyopathy. Dilated cardiomyopathy can cause atrial fibrillation. That will cause clot formation in the left atrial appendage, and if God forbid the clot goes to the brain, he has had a ischemic stroke. The next possibility which is to be kept is paradoxical embolism, a very interesting term. So I would like you to rather listen to the diagram that I made before you. Let us imagine an old man was lying in the bed for long duration. So you know that stasis of blood in the calf veins can occur, deep vein thrombosis can occur. Due to deep vein thrombosis, the clot will develop in the soleal veins in the legs. From there, the clot will go into IVC. From IVC, it will reach the right atrium, from right atria to right ventricle, and then to pulmonary artery, and it can contribute to pulmonary embolism. But in my patient, unfortunately, there is an opening present between the right and the left atria by the name of patent fossa ovalis. So the clots that are starting from the legs, they can go into the right side of the heart, agreed, but then they will go in the left atria, they will go to the left ventricle, and then into the systemic circulation, and can even reach the brain of the patient. Well, the surprising thing is that traditionally with deep vein thrombosis, you read pulmonary embolism because everything that is present in the venous return goes to the right side of the heart. But look at the surprising thing that happened here. The patent fossa ovalis was the villain, which has resulted in the clot moving on to the left side of the heart and then going into the systemic circulation. So paradoxical embolism is of interest to us. Why? Because he will ask you, how would you identify it? Obviously, we can be doing a standard echocardiography, but it might even miss it also because it is relatively smaller. So we will do a special test called as bubble contrast echocardiography. Bubble contrast echocardiography has also been discussed by me in the topic hepatopulmonary syndrome. So when you switch to the liver section, you will see me talking about bubble contrast echocardiography for this rare presentation in decompensated cirrhosis, hepatopulmonary syndrome. And today I have once again talked about bubble contrast echocardiography to pick up patent fossa ovalis, which can actually be responsible for paradoxical embolism. And because of this peculiarity, the examiners love to ask about it. If the problem is not in the heart, it could even be in the carotid artery of the patient. That is why I had taught you that I'll do a carotid artery Doppler. Now, if a person is having a carotid artery atherosclerosis, there is a narrowing of the artery first of all, so there would definitely be cerebral ischemia. And to add insult to the injury, if the atherosclerotic plaque will fissure, then the platelets will jump onto it, clot will be formed, and rather than this clot can fragment also, and there's a shower of emboli into the brain circulation, which can result in multitude manifestations. Because carotid artery atherosclerosis is a nasty disease, there is a surgery that can be asked for it that you would have read anyway in head and neck surgery, that is carotid endarterectomy. But when you tell somebody that we're going to do this procedure, patient will be hell scared because one of the complications of this surgery can be stroke as well. I mean, you're telling the patient we're going to do surgery because we want to prevent stroke, but the surgery itself can cause stroke. So this guy is hell scared. He says, no, Dr. Saab, I'm not ready for this. So what can you do as of nowadays is we can go in for stenting of the carotid artery. So endovascular stenting. So on a comparative basis, I've just put 2 star marks in front of endovascular stenting of the carotid artery as compared to carotid endarterectomy to highlight that the stenting part will be more acceptable to the patients and usually is the procedure that is done. Now the next cause can be that a person can be having even thrombosis. You see, after all, I'm talking about ischemic stroke. Ischemia can occur one because of embolus, that it is starting from the heart, from carotid artery going to the brain, or they can be thrombus formation also. So I'm writing the word cerebral artery thrombosis. Cerebral venous thrombosis I will discuss towards the end of this discussion. At the moment, the objective of discussion is person is having middle cerebral artery / anterior cerebral artery or any artery in the brain having thrombus formation. The clot is not being formed in the heart or in the carotid, it is directly in the brain. So why would that happen? Well, the reason for that is again atherosclerosis, because atherosclerosis not only involves the internal carotid artery but can extend and go and involve the middle cerebral artery also. Then could be some rare causes like thrombotic thrombocytopenic purpura. In fact, if you just go by the word thrombotic, so it can contribute to ischemic stroke. In fact, the highlight of thrombotic thrombocytopenic purpura and how is it different from hemolytic uremic syndrome is the neurological features are present in TTP. Remember, when you do that MCQ in kidney, HUS versus TTP, TTP will always be having fever and also be having neurological features of ischemic stroke. In fact, the topic of thrombotic thrombocytopenic purpura is discussed well in the kidney section. Then can be a rare pediatric cause TET spell because there is hypoxia. Hypoxia will cause polycythemia. Polycythemia means sluggish circulation, and sluggish circulation can again cause a thrombosis. The next important cause is actually genetic. I mean, I'm teaching you a condition where father and son both have died because of development of stroke. So let's have a look at a full form of it first, and then obviously the pattern of inheritance, which you can make up from here only, will be autosomal dominant. Now, obviously, I cannot write as fast as I am speaking, so you have to admit or give me some lag period in this. CADASIL would basically mean cerebral autosomal dominant arteriopathy with subcortical infarcts. SI is subcortical infarcts. So the bad news is that because it is genetically acquired, we need to know about the gene component as well. In fact, this term CADASIL is taught even in pathology, so I am sure that you are familiar with this while I have written it. CADASIL is autosomal dominant, and the gene involved is called as Notch3 gene. In fact, that's one of the favorite with our examiners because genetics is the in thing nowadays. And the highlight of this disease would be that it is not the main middle cerebral artery, but the smaller branches, even smaller than lenticulostriate artery, would be involved in this case. So multiple small arteries can be involved. So it's actually a small vessel stroke, or multiple small vessels can be involved. The clinical manifestations for CADASIL per se can be very surprising. I mean, he might mention migraine-like illness in a person initially, visual complaints. Then we'll say that he started having weakness of his legs or maybe weakness in his arms. The person will also be having features of dementia for previous couple of weeks to months. That could be short-term and long-term memory loss. And on physical examination is having breast DTR. So what you are seeing here is, I mean, what I want you to understand is a global CNS dysfunction. Gray matter is also involved. White matter is all corticospinal pathway is white matter. No, gray matter is also involved. White matter is also involved. So as a result of it, the clinical manifestations of this patient will definitely be having a wide spectrum of presentation. But then genetics can definitely pick it up because he will say that his son was also having, or father is also having similar kind of complaints, or was having similar kind of complaints, and he expired because of it. So it is the causes which are important at the moment. I'll just go back in the slide. I've talked about hemorrhagic, which is easy to identify. Mainly CAA is to be remembered. From the ischemic variety, I mainly want you to focus on the commonest one from the exam perspective, though unknown is written first. The commonest one from exam perspective, the one that we know is non-rheumatic atrial fibrillation followed by bubble contrast echocardiography for paradoxical embolism, where the clot is going to migrate to the left side of the heart and then go into systemic circulation. Carotid artery atherosclerosis is easy, carotid end arterectomy stenting. Then could be CADASIL, which is having a genetic basis, so definitely worth its weight to remember. And now I will just focus on some important aspects that I've told to you with respect to medical care, which will be done in a case of acute ischemic stroke. Broad guidelines I've already given you. I'll now focus on some small micro topics which are important. Well, the main drug that is to be answered here is ritaplase. I have taught alteplase for management of STEMI, but I'm now teaching you ritaplase for management of acute ischemic stroke. In fact, the advantage of ritaplase is that a substantial amount of dose can actually be given as bolus. You don't need to remember the total dose that I'm saying. What I'm saying is, if a person comes right now, if I have to give alteplase, it will be given in form of a drip, so effect will come later. But ritaplase, you give bolus, so the effect will start coming immediately. So usually the max dose that is given is like about 90 milligram, and out of this, 10% is initially given as a bolus. And the advantage of studying this, that ritaplase can be some part given as a bolus, means some effect will start coming immediately. The remaining 90% of the dose that is left, the remaining 90% is given over 1 hour in the form of a drip. The basic concept I just wanted to explain was streptokinase is given as infusion. Alteplase is usually given in form of infusion, but ritaplase can be given in a bolus format as well. Along with this, strict blood pressure monitoring is to be done because you can be having hypertensive crisis even in ischemic stroke, no? There is not a guarantee that hypertensive crisis will always contribute to hemorrhagic stroke. The normal thought process is, if it's going to be hypertensive crisis given, it is a question of hemorrhagic stroke. No, hypertensive crisis can occur in ischemic stroke also. So now listen to my next statement very, very carefully, that if BP monitoring is being done, we obviously need to regulate the blood pressure. I'll tell you the cutoffs in this case. Let me say, I'll divide this into two parts. Suppose a person is a candidate for thrombolysis. That means that he had come early. On the other hand, he is not a candidate for thrombolysis in a sense that he woke up with stroke manifestations. He went to sleep at 10 p.m. in the night, woke up at 8 a.m. So the onset is from 10 p.m. in the night. That is more than 4.5 hours already. If the person is candidate for thrombolysis, you have to ensure that do not do thrombolysis. I mean, thrombolysis is going to be contraindicated if the blood pressure is more than 185 by 110. You first have to lower the BP to lesser than this value and then do thrombolysis. But if he's not a candidate for thrombolysis, then the cutoff is 220 by 130. I repeat the facts once again. You are having two patients of acute ischemic stroke in a hospital at the moment. One who woke up in the morning, had a morning cup of tea, talked to his son, grandson, was joking with his grandson on the dining table when he is having his breakfast at 8 a.m. That is when suddenly he had aphasia, facial weakness. So everybody noticed that. Second is an old man who woke up with symptoms of stroke. If somebody has had a stroke few hours back, 2, 3, 4 hours, then obviously he's a candidate for thrombolysis. If he's having a spike of BP, try to keep the BP less than the value that I mentioned. Like I'm saying that if he comes with high BP, lower the BP and then do thrombolysis. But if he's not a candidate for thrombolysis and suppose the blood pressure is 200 by 100, no point in trying to lower the BP. He says the intervention is to be done by after 220 by 130. That's a very fine point that I want you guys to remember, that obviously for hemorrhagic stroke we study about controlling the blood pressure part, but even you can ask about that in the ischemic stroke component also. Apart from this, I have highlighted that do not give any aspirin or antithrombotics if you have done thrombolysis in the patient at least for the first 24 to 48 hours. The reason for that being specifically that you could have a bleeding since he has already undergone a thrombolysis. Now the bad news is sometimes in spite of doing all this, there would be worsening of symptoms of the patient, which tells you two possibilities. One possibility is that the bleeding is occurring because of the treatment you had done, because what is the biggest side effect of thrombolytic drugs? Bleeding. Second, sometimes ischemic stroke can get converted into hemorrhagic stroke. So how would you know that the person is having worsening of symptoms? Obviously, the GCS score of the patient will start deteriorating. Like when he came, GCS was 13, now it has reduced to 8. In those circumstances, especially when you are doing thrombolysis, like suppose at the moment the drip of retaplase is being given and the person is having deterioration of sensorium. In those circumstances, he says stop the infusion per se of the drug, the thrombolytic drug, whichever is going, because it is causing a bleeding. You see, the point is thrombolytic drugs have their own side effect also. So in those circumstances, if you are giving the drug right now and there is a deterioration of GCS, stop the infusion and then give cryoprecipitate for the patient. Now, why am I emphasizing this is because in my cardiology discussion, I have taught you that suppose you are giving streptokinase to somebody and he starts having a brain bleeding. Streptokinase toxicity, the antidote was taught to you as ECA, epsilon amino caproic acid. But today I've taught you that if a person is having a retaplase toxicity, the words are streptokinase toxicity, retaplase toxicity, then for retaplase toxicity, we will give cryoprecipitate. I also want you to remember that cerebral edema per se can also develop in a patient of acute ischemic stroke. So let's have a look at the timelines. I mean, when do you have cerebral edema and what is the type of cerebral edema? First of all, I want you to remember that in stroke, the type of cerebral edema that develops would be cytotoxic. In neurocysticercosis or brain tumor, there is a vasogenic cerebral edema, but here it is going to be a cytotoxic cerebral edema, which will be seen usually by day 2. In fact, in some cases, it might become so severe that it might start causing a mass effect. That is, the swelling will contribute to pressure on the ventricles as well. The mass effect will usually come by day 10. So what are the steps to be taken? For cytotoxic cerebral edema, we can definitely use mannitol, but we do not use mannitol for vasogenic cerebral edema. Assuming that you have not listened to me carefully in remaining lectures, question for you guys, can you tell me the drug of choice for vasogenic cerebral edema? In cytotoxic cerebral edema with a stroke patient, I have done water restriction, I have given mannitol. If it is still causing a mass effect, I can do a hemicraniectomy. So hemicraniectomy is what I taught you earlier for hemorrhagic stroke, but I'm not teaching you that even in ischemic stroke. Remember, the topic is medical care in AIS. Even hemicraniectomy might be required. Why? Because of the mass effect caused by the cytotoxic cerebral edema. The question is still open, guys. What is the drug of choice for vasogenic cerebral edema? 2 times where I've taught you vasogenic cerebral edema is neurocysticercosis and brain tumor. Yes, you would have guessed it right by this point of time. I gave you sufficient lag to remember it. Vasogenic cerebral edema is treated with dexamethasone, whereas the cytotoxic one is managed with the help of mannitol per se. There is also possibility that sometimes the brain hemorrhage patient will deteriorate. One possibility is ischemic stroke might get converted into brain hemorrhage also. That, you see, I have said 2 points. One is the drug that you were giving is causing a brain hemorrhage. That is one possibility, right? But that will happen when you're giving the drug. Suppose the infusion is over. You gave infusion yesterday and brain hemorrhage is occurring today in a ischemic stroke patient. That is because of the spontaneous conversion also. Let me teach you one more score here, that is called as ICH score. Prior to this, I've taught you regarding ABCD2 score. Now, why am I talking about this intracranial hemorrhage is because of the following reasons. You see, one reason for intracranial hemorrhage can obviously be trauma. Second possibility for intracranial hemorrhage is that he's having warfarin toxicity. Third possibility is that person was being given thrombolytic drug. Thrombolytic drug resulted in brain hemorrhage. Fourth possibility is that after few days of thrombolysis, the ischemic stroke got converted into hemorrhagic stroke. Four possibilities. I repeat that again. Trauma, warfarin toxicity, during thrombolytic administration. During thrombolytic administration. Last can be post thrombolytic administration. You have done thrombolysis yesterday. Today the bleed started. It occurred on the same side or maybe on the contralateral side. ICH score is only used to prognosticate, but since this score is given in the book, it is a good idea to actually study about it. You just need to remember the parameters. Nobody will ask you to score it in the exam. In ICH score, we take into consideration first the age of the patient, obviously that is important. Then is hematoma volume, whether it has extended into the intraventricular cavity, that is intraventricular hemorrhage has occurred or not. If the bleed is gonna be infratentorial, it means bad prognosis because brainstem will be involved and then the GCS of the patient. So let's revise what are the parameters: age, amount of bleeding, location of bleeding, extension into IVH, and the GCS status. Next is, I'm just saying for the sake of completion, I mean, if the age of the patient is less than 80 or more than 80 years, it obviously will make a difference. When it comes to hematoma volume, less than 30 versus more than 30 cc will definitely make a difference. I mean, that's based on the amount of blood that can accumulate and the neurological deficit that can occur. A person is not having a IVH versus a person is having a IVH extension will make one whole of a difference. So is the location, because if it's going to be in the brainstem, chances of brain herniation will be increased. And then I'm mentioning some GCS scores before you. You are aware of the fact that GCS score less than 8 would signify presence of a coma. And now I'm putting one more entry here as well to tell you that actually in ICH scoring, though now I put numbers here to basically sensitize you to the fact that we are having nowadays apps available in which you just need to feed this data, and based on the age of the patient and the other parameters, you can actually determine the prognosis of a patient. The maximum score possible with respect to a patient who's having ABCD2 score was told to you be 7, but when for ICH score we calculate, the maximum score possible will be 6 in a person, and that means that we need to take a decision for hemicraniectomy in the patient. I have today highlighted that if it is warfarin toxicity or he might write the word vitamin K antagonist, then it is primarily to be answered as prothrombin complex concentrate. If it talks about NOAC toxicity, right, I'm talking about both the toxicities in this case, then it is a monoclonal antibody. By this time, I hope you are remembering the name. That was idarucizumab. Monoclonal antibodies are anyway, very extensively asked. So that's why I thought I'll explain this to you. And lastly, I would like to mention regarding a rare topic which is asked in stroke, that is cerebral venous thrombosis. You see, we study about arterial strokes, no? But there can be venous strokes as well. You see, when you read this for the first time, I mean, it looks surprising because the impression of most of us is that stroke is always going to be an arterial occlusion. No, even venous occlusion will cause it. Why? Because after the blood of artery has to go in the vein, if the vein is occluded, the brain perfusion is affected once again. In cerebral venous thrombosis, it could be involvement of mainly the sagittal sinus, or it could be the lateral sinus also. So they are the ones which are relatively bigger. So the involvement of the bigger ones will cause more profound manifestations in a person. Now, before I describe the manifestations, he usually loves to ask you the risk factors, and one of them is obviously the older generation of oral contraceptive pills. Pregnancy is anyway a hypercoagulable state, so post-pregnancy venous stroke could be occurring. It could be postpartum as well. These are the usual triggers that can be given in the question, and now comes the core issue. You are aware of the fact that we have an anti-clotting system in our body. That is what has started within TIA. Protein C, protein S, and antithrombin 3, if they are less in the body of somebody, maybe due to cirrhosis of liver, because after all they are also produced in the liver also, then even a hypercoagulable state can develop. Like I've taught you, the most common bleeding disorder happens to be von Willebrand disease, not hemophilia. I'm teaching you one of the commonest hypercoagulable states, which is called as factor V Leiden mutation. Well, what is the problem in factor V Leiden mutation is that normally factor V and protein C, they keep each other's activity in check. But now what will happen is there would be a protein C resistance. I want to highlight this fact once again. Factor V and protein C, they keep each other's activity in check. But in this case, the protein C and protein C and factor 5, the activity or the binding will not be. They are not able to bind to each other properly. So the unopposed activity of factor 5 will contribute to thrombus formation. Another hypercoagulable state that they love to ask you because of the peculiar nomenclature. It is called as prothrombin G 2021. 2020 has been a horrible year, so you just can remember this number 210 mutation, prothrombin G. Again, in this case, it's actually a hypercoagulable state and is being discussed. Antiphospholipid antibody syndrome has been discussed with SLE. Then can be polycythemia, which will be having increased RBC mass and again can contribute to cerebral venous thrombosis. So these are usually the triggers, and I'll put it like this. Like if somebody is having factor 5 laden mutation, hypercoagulable state in a female, she's not aware that she's having this hypercoagulable state. She's 24, 25 years of age. Still, by the time she turns pregnant, or if she starts using protection in the form of OCP. I'm saying a lady with factor 5 laden mutation might be asymptomatic for the first 2 years of her life. It's only when she gets married that she turns pregnant, or if she's starting to use OCPs, that is when the manifestations may occur. Let us now look at what are the clinical manifestations that will be given in cerebral venous thrombosis. He will give you the standard features of raised ICP like headache, projectile vomiting. Then we'll describe also this lady having seizures. Let me say pregnant lady having seizures. You might be thinking it could be eclampsia, pre-eclampsia as a presentation. But then the deficit that will develop in the body, it could be written as hemiplegia, it could be written as paraplegia. That points to the fact that this question is not about per se the standard OBGY scenarios of eclampsia that they give you, because you don't read about neurological deficits in this case. Features of raised ICP will develop in the form of posturing. There could be Cushing reflex, there could be Byers breathing, there could be Cheyne-Stokes breathing developing in the patient, and then subsequently the patient will become stuporous and go into coma. The main highlight is if you read about a lady postpartum or at least during delivery, she's having a focal neurological deficit. Initial impression is obviously the OBGY scenarios of preeclampsia and eclampsia, but then you don't read about these focal deficits and raised ICP in the two situations that I mentioned. In fact, if you are going to do a workup of patient of cerebral venous thrombosis, the non-contrast CT head will be normal in majority of cases, even in the later part of the disease. In acute ischemic stroke, I was saying that CT is initially normal, then hyperdense MCSI, then a hypodensity. Here it might be normal even after, let me say, 10 hours, 12 hours also. So the investigation of choice for cerebral venous thrombosis should be answered as MRV, that is magnetic resonance venography. And then we need to start treatment. And the treatment is the key thing that he would like to listen from you, that you are not gonna give thrombolytics in this case, because when it's an arterial clot you use thrombolytics, but if it's a venous thrombus you are gonna use heparin in this patient. Along with this, these patients would also be put on warfarin on long-term basis. In fact, warfarin might be given in these patients for as long as 3 to 6 months, and they will also be put on long-term lifelong aspirin. You will put these patients on aspirin if they are documented to have thrombophilia, that is those rare conditions I was talking about. One of the rare conditions I spoke about was factor 5 laden mutation. Another one I mentioned was prothrombin G 2021 G mutation. I spoke about it. And then even deficiency of the anti-clotting systems. So if he gives you a scenario thrombophilia, then lifelong aspirin would be required for these patients. In fact, when I've discussed antiphospholipid antibody syndrome, even in antiphospholipid antibody syndrome, lifelong aspirin has been discussed. So towards the end of this discussion, I mainly focused on the etiology behind development of this. Two scores which are important are ABCD2 and rather the ICH score, where it is the parameters which are of importance. You don't need to remember the right hand side, that is the values per se. They'll never give you a CT and say, okay, this much volume of blood, now calculate the ICH score of the patient. And then the routine medical aspects of AIS that are highlighted are the ones which are usually asked. And over and above this contraindication for thrombolysis that I mentioned, this is extensively asked, guys. I mean, contraindication per se. He can twist the MCQ by introducing a contradiction, so contraindication. So you definitely need to be able to work up the data. I agree that I said a lot of things here, and obviously it was a relatively a longish lecture, so the concentration tends to go down. But I'm very sure that if you get the stroke chapter right, if you get TIA stroke interventions right, you would definitely be able to score over your rivals. So keep hammering, keep learning, guys, and as you keep on upgrading, your scores will automatically increase. Thank you so much for your patience and hearing me out.